Hello, my name is Lisa Hendricks and I'm a pulmonologist specializing in lung cancer at the Maastricht University Medical Center in the Netherlands. I'm joined today by Suresh Sanan, Professor of Clinical Experimental Radiotherapy at the Amsterdam University Medical Center, also in the Netherlands. Welcome, Professor Sanan.
Thank you.
In this section, we will be discussing the question, what is the rationale for using immune checkpoint inhibitors in limited stage small cell lung cancer? I think also to be friendly, I think if Professor Sanan is okay, we will have first names for the rest of the discussion.
Certainly, Lisa.
So, Professor Sanan, before we delve into the future directions and use of immunotherapy for small cell lung cancer, can you tell me something about the current standard of care for limited stage small cell lung cancer and why there are so many unmet needs in this stage?
Thank you. The current treatment for patients who are fit and with disease which is encompassable within a radiation field is concurrent chemoradiotherapy with a platinum doublet, followed by prophylactic brain irradiation depending on local standard of care. The problem we have now is high rates of local and distant failure, with just about 30% of patients surviving 5 years, and the median survival is between 25 to 30 months. These poor results highlight the need for improvement. Unfortunately, in the last 30 years, we've not really made much advances in systemic therapy, and cisplatinum or carboplatinum with etoposide is, in many parts of the world, the standard of care. So we have to clearly improve on these results that we mentioned. And that's the current landscape before the immunotherapy trials.
I think in the current landscape, I think there's still also an ongoing discussion about once daily or twice daily radiotherapy. What's your opinion on this, also in light of the common questions for immunotherapy?
So the initial trial, which established the role of twice daily radiotherapy, showing a survival benefit for that, had in the comparator arm once daily 1.8 gray per day to 45 gray. And that was a big issue for many people because that's not a standard dose. The standard dose of concurrent chemoradiotherapy is now 60 gray and sometimes 66 gray. And that's our current benchmark. So one reason for reluctance to accept the results of the twice daily or BID radiotherapy has been the use of an inferior comparative arm in the initial study, which can be explained by the fact that concurrent platinum-based chemoradiotherapy was considered fairly toxic because of the large radiation fields used at the end of the last decade. So studies which tried to use a higher dose of radiation did not show a superiority above the twice daily BID. So many clinicians around the world still use once daily to about 60 to 66 gray. And these studies which have been designed to show the superiority of once daily radiotherapy have not shown that to be superior to twice daily. So it's a question of local practice, patient convenience that's been determining the choice of radiation schedule to the chest.
I think, and as you already mentioned, the local but also the distant relapse rate is quite high, and most of these patients die from metastatic small cell lung cancer in the end. So we want to improve the outcomes of these patients, and in contrast to small cell lung cancer, for non-small cell lung cancer, immunotherapy is becoming standard of care for almost all disease stages except for the very early disease stages. Also for non-small cell, we have the Pacific trial, for example, so stage 3 non-small cell concurrent chemoradiotherapy, adjuvant durvalumab, so immunotherapy. Do you see a rationale to use immunotherapy and radiotherapy combined or in sequence also for small cell lung cancer?
Certainly, the rationale is there. I think it's fair to say that there have been about 4 phase 3 trials showing a benefit, survival benefit in patients with extensive small cell lung cancer when immunotherapy was incorporated with chemotherapy. So that gave us a feeling that you could actually improve survival. Having said that, the average survival gains was between about 2 to 2.5 months, which is not very exciting, showing that there is a signal when you use chemotherapy only, but it's quite a weak signal, I would say, compared to the results we're seeing in metastatic non-small cell lung cancer. So it made sense to try and evaluate immune checkpoint inhibitors in limited stage small cell lung cancer as well, to see whether we could improve on the results for patients with non-metastatic small cell lung cancer.
And if you touch upon the preclinical rationale to use immunotherapy and radiotherapy in combination, you do a lot of research. Can you elaborate a little bit on this?
So the preclinical data and some clinical data supports the synergy between the two modalities, immunotherapy and radiotherapy. Radiotherapy by causing cell death, antigen release, and priming of the immune system may facilitate subsequent action of immunotherapy. And there have been trials, for example, the Stimuli trial, which evaluated standard concurrent chemoradiotherapy followed by either standard of care or dual immunotherapy with nivolumab and ipilimumab. So that did not show favorable results, but it was not a very large study, and perhaps the tolerance of dual immunotherapy was in question because the average time on treatment was quite short. Yet another approach is to combine immunotherapy during the delivery of concurrent chemoradiotherapy and not after that. So single institution trial evaluated pembrolizumab with concurrent chemoradiotherapy, and the toxicity appeared acceptable, but this was a single arm study enrolling just 40 patients. So some preliminary work suggesting that perhaps consolidation with two agents was not feasible, but that concurrent with a single agent, pembrolizumab, was feasible.
Yeah, and I think after these trials, or even while these trials were ongoing, multiple other trials were ongoing evaluating adjuvant immunotherapy. So mainly phase 2 clinical trials, but also some phase 3 clinical trials. Can you give a short summary about the highlights of these clinical trials?
So the major phase 3 trials have evaluated these immune checkpoint inhibitors either during the concurrent chemoradiotherapy phase or as consolidation after that. So the Adriatic study, for example, the Surpass trial with sugemalimab, all investigated the addition of single agent immune checkpoint inhibitors after completion of standard chemoradiotherapy in patients who are fairly fit. Another approach was to combine it during the treatment, and that's the approach taken in the NRG-LU005 trial, where atezolizumab was combined concurrently, and then in the experimental arm, it continued for 12 months. And we also have the KeyLink trial, where pembrolizumab was administered concurrently, followed by either pembrolizumab only for 12 months or the combination with olaparib. So the attempts to incorporate immunotherapy earlier in the sequence is an attempt to prevent patients who progress early from dropping out. And the consolidation approach is akin to the Pacific trial approach in non-small cell lung cancer, where you pick out the fit patients who have completed the standard treatment and then randomize them to immunotherapy or placebo.
Yeah, and with the current data available, and we will also discuss this in the two other Zoom recordings that will still follow. Can you comment a little bit already on the outcomes of these trials and how you think we should move forward?
What's been clear from the data presented to date is that just like in the Pacific trial in non-small cell lung cancer, the consolidation approach with single-agent durvalumab was positive for the dual primary endpoints of overall and progression-free survival in the Adriatic trial. So the Adriatic trial at the first interim analysis showed 27% reduction in the risk of death. And this was, and the median overall survival benefit was substantial, close to 2 years, when durvalumab was administered for up to 24 months. So that's been a major breakthrough for patient care, and that is now undergoing, the study is ongoing to see whether the combination of durvalumab with tremelimumab, that study arm also shows any benefit. And this seems to be a development that is going to, seems tolerable, and has also been able to show a significant improvement in median survival. We have some early data from the NRG LU005 trial, which suggests that administering an agent during concurrent chemoradiotherapy may not be so favorable.
And if you look at the Adriatic trial results, so a huge difference in median overall survival, but the curves keep separated. And if you compare this huge difference to the, I think, quite moderate difference for extensive stage small cell, is this due to the radiotherapy patient selection? Why do you think this difference is especially found in the concurrent chemoradiotherapy adjuvant immunotherapy setting for small cell?
I think you pointed out a very intriguing finding. This would not have been what we would have expected based on previous experience in extensive small cell lung cancer. It raises the possibility that prior chemoradiotherapy may prime the lung tumor microenvironment so that the biology of the tumor may not be as important as the pre-treatment. So it's speculative, but the order of magnitude of benefit has been so much different from what we see in extensive small cell. You can only conclude that the chemoradiotherapy priming has done something to enhance the efficacy of subsequent consolidation development.
I think lots of food for thought. So thank you, Professor Sanan, for discussing these interesting data with me. Also thank you, the audience, for listening. And I would like to remind you there are 2 other recordings also discussing immunotherapy in this disease setting, I think quite worth listening to. Thank you.
Hello, my name is Dr. Jacob Sands. I'm a thoracic medical oncologist at Dana-Farber Cancer Institute, where I lead our small cell lung cancer program. I'm joined today by Dr. Suresh Sanan, a professor of clinical experimental radiotherapy at the Amsterdam University Medical Centers in the Netherlands. Welcome, Professor Sanan.
Thank you.
In this session, we'll consider the question, what are the key data for immune checkpoint inhibitors in the treatment of limited stage small cell lung cancer? Now, Suresh, we've got a handful of studies to get through, but there are really 2 key main ones that I think are worth discussing. But first of all, can you just give us a flavor or a sampling of some of the various checkpoint inhibitors and studies that have some data out there? And then we'll go through them maybe a little more selectively.
Yes, certainly. We have the phase 2 trials, which are ongoing, and the large phase 3 trials, 2 of which have reported some findings. So the phase 3 trials are those of the Adriatic for durvalumab, atezolizumab in the NRG 005 trial, and the eribrimumab trial, which is ongoing. And these are studies, phase 2 and phase 3, in 6 different agents with different combinations, and they're going to reveal some interesting data on what could be feasible.
Yeah, and let's jump first into, I think the one really to highlight in all of this is Adriatic. We had positive data that was reported, median progression-free and overall survival that was really impressive. What was the data and what were your thoughts about it?
So the Adriatic trial is an ongoing trial, 3-arm, and it could patients who completed standard concurrent chemoradiotherapy to the chest, with or without subsequent prophylactic brain irradiation, were randomized to either placebo, to single agent durvalumab for up to 24 months, or the combination of durvalumab with tremelimumab. And data from the durvalumab versus placebo arms were presented at the ASCO meeting and published recently. And the main findings were the significant improvement in median overall survival of nearly 2 years, and the median progression-free survival improved from 9.2 months in placebo to 16.6 months with durvalumab. And the safety profile was quite good in the sense that the incidence of pneumonitis was increased by about 8%, but the grade 3 and 4 pneumonitis rates were 3% or less in both study arms. So we're seeing an improvement in survival, which is far greater than what we would have expected looking at the data for chemoimmunotherapy in extensive small cell lung cancer.
Yeah, I think a lot of people were really surprised. So just to compare to, in the metastatic setting, we have the Caspian trial. So first-line extensive stage, we have the approval of platinum etoposide plus durvalumab, that by median progression-free survival was not different than the chemo alone, but by median overall survival was a 2.7-month difference, which is what led to FDA approval. Now, the 2.7 months is not overwhelming, but it's the tail of the curve that looked so good. And this has become standard of care in the first-line setting and enthusiastically used because of the tail of the curve looking so good. So I think people kind of expected this similar minimal changes in medians. So we now see a median progression-free survival of 7.4 months and a median overall survival difference, as you said, 22.5 months is a shocking number. But the shapes of the curves actually look very similar to what we see from the shape of the curves in the Caspian trial. And I encourage everyone to kind of pull up those studies and look at them. And what that shows you is a further validation of durvalumab working the way that we expect it to, the way that we've seen it work. And this median difference represents the control arm doing so much better than what we see in the extensive stage setting, which again highlights the challenges in small cell lung cancer and the real opportunity in limited stage disease. I think one thing for us to keep in mind going forward, as this is becoming a standard in my practice, is trying to differentiate what might be from durvalumab as opposed to from these other contributing factors. And so from a toxicity standpoint, differentiating that is important then as far as then management in utilization of durvalumab going forward, or whether I think patients need to be held for some reason. But to also highlight now, this trial, the Adriatic trial, enrolled patients after they'd completed concurrent chemo and radiation, which is quite a bit different than the next study we're going to discuss, the NRG-LU005. This was the use of atezolizumab that was starting basically at the start of radiation along with cycle 2 of the chemotherapy. Surprised me a bit to see this as a negative trial. Did that surprise you? And what were your thoughts overall of the NRG-LU005?
So like yourself, I was surprised because if you look at the median, it was about 6 months shorter. And we were somewhat prepared for this by the PACIFIC-2 trial in non-small cell lung cancer, where we also saw that giving concurrent durvalumab with chemoradiotherapy followed by maintenance durvalumab actually was no better than standard of care chemoradiotherapy without any immunotherapy. So the message coming out from this study design of concurrent administration of IO seems to resonate also in head and neck cancer. We're seeing the same thing in many trials, lack of benefit. It may be that the concurrent administration of chemo, radio, and immuno sort of wipes out the beneficial effects of adding immunotherapy to systemic therapy, whereas administering at consolidation seems beneficial, but like you pointed out, you're selecting out the good players, those who have performance score 0 and 1, and that may be a way of selecting. So the points that's highlighted is there's some patients not quite benefiting yet from immunotherapy, and maybe we have to design other drug sequences or explore other agents to make sure that more patients make it through without progression in the first part of their treatment.
Excellent points. Now, I'm going to breeze through a handful of others just to mention them. We have the adabrelumab study that is with concurrent chemoradiation. You see here now, the treatment-related pneumonitis was about 14%. I think as we're teasing apart the radiation and immunotherapy, sometimes there are overlap in these. Response rate of 93%, although we expect a high response rate when giving chemo and radiation, still early on with this study. Now, we also have serplulimab, toripalimab, camrelizumab. Serplulimab and camrelizumab, both, this is pretty early data still, so I think we'll see what happens as these mature out. Toripalimab showing a 2-year progression-free survival of 61.6% relative to 34.8% in observation. Just to give some cross-trial comparison, not to directly relate them, but maybe frame of reference, is that within the Adriatic, the 2-year progression-free survival was in the 40s%. So this compares quite favorably, although still early, and I wouldn't make broad conclusions from that cross-trial comparison, but just to say it does compare favorably, and so we'll see what happens with further study in that. The overall survival difference at 2 years, 82.7% versus 59.1%, not statistically significant, but certainly a fairly broad separation there with lower population. As far as the pneumonitis, there wasn't a drastic difference, but again, these are smaller numbers. Now, we also have a handful of trials here in China, 2 of them being neoadjuvant regimens. I find this to be quite compelling, although I think running a neoadjuvant regimen is really challenging in making sure you have true full staging while also not delaying starting treatment. So I applaud the effort on these. These are still low numbers. I wouldn't draw actual clinical decisions yet, but I'm excited to see these areas of study. Also, a retrospective study of first-line chemotherapy plus minus checkpoint inhibitor. Now, surgical resection, what are your thoughts on this? Are there patients that you think in clinical decision-making you would consider in making sure a surgeon had seen?
Certainly stages 1 and 2, low volume, non-bulky disease, I think surgery has a clear role to play. And with the advent of better systemic therapy with chemoimmunotherapy, I think the role really needs to be explored, because we do see quite high rates of local recurrences in both the Adriatic and in the LU 005 trial. And I think as we wait for the more mature data, we will find there's a subgroup of patients in whom perhaps initially operable disease should be reconsidered in the immunotherapy era.
Now, Suresh, we've gone through a handful of these trials now within the limited stage setting and incorporation of immunotherapy. Is there any indicator as to which population of patients are really going to benefit from these, or are we kind of going broad populations here?
Unfortunately, we have to settle for broad populations because we do not have any data to suggest how the particular subgroups which can benefit more or less. However, I'm hopeful that when the comparative tissue analysis data from both these completed phase 3 trials become available, we will get more insights. But at this point, it's for all comers with the limited small cell lung cancer.
Well, thank you, Suresh, for running through that data with me. It's a lot to cover. It's exciting to see some of the advances that we're noting in the field, and clearly there's more data to look forward to. And to you watching this, we appreciate you joining us today, and please check out the other sessions in further discussion around limited stage small cell lung cancer.
Hello, my name is Suresh Sennen. I'm a professor of clinical experimental radiotherapy at the Amsterdam University Medical Centers in the Netherlands. I'm joined today by Dr. Lisa Hendricks, a pulmonologist specializing in lung cancer at the Maastricht University Medical Center, also in the Netherlands. Welcome, Dr. Hendricks.
Hello.
And we're delighted to have Dr. Jacob Sands, a thoracic medical oncologist specializing in small cell lung cancer at the Dana-Farber Cancer Institute in the USA. Welcome, Dr. Sands.
Happy to be here.
So we're going to consider the question now as to what impact could immune checkpoint inhibitors have on the management of patients with limited small cell lung cancer. So my first question to the both of you, and firstly to Lisa, is where do ICIs fit into the current treatment pathway for patients with limited stage small cell lung cancer?
I think for this question, we need to look at the data and, of course, also the approvals. And I think so far we only have one positive phase 3 clinical trial, so the Adriatic, to shortly summarize concurrent chemoradiotherapy followed either by durvalumab or placebo, and the trial was very positive for overall survival. Median overall survival almost 56 months in the durvalumab arm, and around 33 months in the other arm. So I think there is a huge overall survival benefit, hazard ratio 0.7 approximately. So I think this is a huge step forward. There is already FDA breakthrough designation. I assume Dr. Sands is already giving this, but I think for the Europe, there is no EMA approval. There is no access yet. So for me, no option at the moment, but yeah, I think there is really room to give this in the adjuvant setting. So far, other trials giving immunotherapy concurrent with chemoradiotherapy, the Energy Lu 005, for example, have been negative. So for me, in the adjuvant setting at the moment.
Jacob, your views on this?
Yeah, and so certainly in the extensive stage setting, it is a first-line standard of care to give with chemotherapy. But I agree, in the limited stage setting, we have one trial that's definitive at this point. I consider the use of durvalumab in the maintenance setting after concurrent chemoradiation to be the standard of care. And it's something that I've started utilizing for patients at this point. It is 2 years of durvalumab after chemoradiation. There certainly could be discussion about how long patients need, but I stick to the 2 years the way that it was done in the trial. That's certainly the goal, unless there are toxicities that come up.
Could you tell us whether we are in a position to select appropriate patients using anything other than the TNM staging system?
So unfortunately, we really don't have a good biomarker in the setting of small cell lung cancer. TMB, PD-L1, these have been looked at, but haven't really been definitive. I guess the one thing I would point out, which is rare, but if I have somebody that never smoked and has small cell lung cancer, then I think genomic testing is really important in that setting. I have patients that I've seen with EGFR mutations, so very likely a de novo transformation. This was not on targeted therapy, but de novo transformation to small cell. I've seen MET exon 14 skipping mutation, but in somebody without a smoking history, I would then question whether there is some kind of actionable genomic alteration that's a part of that diagnosis. And those might be outlier scenarios that I don't necessarily use immunotherapy, but these are really quite rare.
Okay. So can I ask you, Lisa, based on the results of the Lu 005 trial, do you think there's a concern about administering a concurrent IO during chemoradiotherapy in limited stage small cell lung cancer?
Yes, I think there is. Well, the trial was negative, so probably you're not selecting the right patient. It could also be that the radiotherapy combined with the immunotherapy doesn't work synergistically, and you have an increased risk for toxicity. And I think you can have the parallel with stage 3 non-small cell lung cancer. So the Pacific-2 data, same principle, was also negative. And we also had the data for the Checkmate 73L, the press release. We haven't seen the data yet, to the best of my knowledge. Also negative, either with dual immunotherapy in the adjuvant setting or with concurrent immunotherapy. So I think so far there are a couple of phase 3 trials that have read out negative if you can give it concurrently.
So perhaps, since you mentioned that you're not cleared to use durvalumab in limited small cell lung cancer, perhaps I can ask you in the Pacific setting, how do you address the concerns of immune-related adverse events, and how do you monitor your patients to ensure that they are getting appropriate and safe care with management of potential toxicities?
Yeah, I think we have a quite standardized workup for new patients with suspected lung cancer. So in this standard workup, we also ask for autoimmune disease, immunosuppressive medication, and we really revised the chest CT images to see whether there is already a hint of an interstitial lung disease, because we know that patients with an interstitial lung disease or already a medical history of autoimmune diseases have an increased risk of immune-related toxicities, and especially pneumonitis. After treatment, and of course, these patients get instructions when they need to call the physician. So they have these alarm cards with instructions when to phone. And of course, every time you see these patients, you ask for symptoms and you try to see whether they have any immune-related toxicity. And I think it's also very important to know that even if you discontinue the immunotherapy, either due to disease progression or because you reached the end of the adjuvant treatment, these patients can still have late immune-related adverse events. I've seen hypophysitis, myocarditis, I think 1 or 2 years after the cessation of the immunotherapy. So it's also something to instruct your patient and the GP, because quite often these patients don't phone you 1 year after the immunotherapy, they phone their GP, that if in doubt, check for immune-related toxicity.
So Jacob, could you tell us about which guidelines apply in your practice for management of side effects, and whether you anticipate that giving durvalumab for 2 years in the Adriatic scheme might lead to different issues compared to Pacific just giving it 12 months?
Yeah, somewhat. I mean, I think the longer that someone is on a drug, the more likely there are things to come up. And so I think the points Lisa made are really important as far as being really mindful about some of the less common ones that can come up and less obvious. So adrenal insufficiency is something you have to keep in mind. It doesn't necessarily stick out like some of the others. Of course, nephritis is something to be aware of. Myocarditis, another one that isn't always so obvious, but you have to remember. And then even things like a type 1 diabetes we'll sometimes see, and that really requires acute management. Overlapping with radiation, as you highlighted, is a pneumonitis, and differentiating that as a radiation-induced as compared to a checkpoint inhibitor-induced is important. And I love that our radiation oncologists in the chart put the radiation plan, at least, a few slices of that plan, so I can see generally the radiation fields, which I think helps quite a bit in trying to decipher whether something might be radiation-induced versus durvalumab-induced. And then, the more common things like thyroid function being affected is something that in the longer term to remember to continue to monitor, because if someone has no longer on active treatment, sometimes it's not as obvious to remember to continue to monitor that as a potential later toxicity. So it's really important to just keep these less obvious ones in mind. And when symptoms develop, think about what could have possibly been causing that may in fact be related to the checkpoint inhibitor, just to make sure you're not missing something.
How often do you manage to reintroduce durvalumab after a grade 2 radiation pneumonitis? What is the time scale in your experience where you can control the symptoms, observe recovery, and recommence immunotherapy?
Well, so in the small cell setting, this is still pretty early as far as adoption of standard of care. We did enroll to clinical trial, and so on the trial this is outlined. So I have a far more experience as far as numbers in with Pacific for non-small cell after chemoradiation and then being on durvalumab. And I think in that setting, there are scenarios where if someone has a grade 2, that after they've recovered, I will reintroduce durvalumab. Typically, that is something where if I start dexamethasone and they have immediate resolution of their shortness of breath and they're fine, and I can kind of do a short taper and they come off of it and they're still fine, then in those cases, I may reintroduce the drug. Some of it also, I mean, certainly depends upon the patient. If the patient is saying, okay, but I really want to be back on the drug and they feel fine and they're active and I know that they're going to reach out to me and I'm not worried about missing something, then I'll reintroduce. If somebody has a grade 2, but like, a deeper grade 2 that they're really affected and they don't have as good a functional status at baseline, or they live really far away and they're not as reliable as far as reaching out to me, or not as clear, then I'd be a little more nervous about reinitiation. But generally speaking, if I think it's safe, I do try to continue the drug. Now, that being said, it also depends upon time frame. If they're just 2 doses in and this happens, as opposed to if they're, in the Pacific study, if it's kind of just their last dose that they haven't gotten, then I may be more inclined to say, okay, we're done, as opposed to reintroducing. Now, in this setting with small cell lung cancer, when you're talking about 2 years of time frame, the further along they get, the less inclined I am to try and push to continue it. I think there's a spectrum of different factors that I take into account.
Thank you. Lisa, if I could ask you mentioned that the problem of late manifestation of endocrine toxicity. So in your patients with the Pacific regimen after 12 months when they stop, do you have any advice on what sort of monitoring, for example, thyroid functions or full blood screenings and liver functions that you advise them to have through their general practitioner after the 24, 36-month period?
Yeah, I think maybe in the Netherlands or in my hospital, we're not so good at letting patients go, so we follow them ourselves. So usually the first 2 years after treatment, I see them every 3 months, and then I have full blood count, renal function, liver test, at least thyroid. And if I'm in doubt, the patient deteriorates, I have a signal for adrenal problems, then of course I do additional endocrine tests. And usually after 2 years, we go to every 6 months and instruct the patient to call in between if there is something. So I think in general, we are quite easy to reach, low threshold. I think you cannot burden the GP with all of these patients, and I think for us it's easy. It's a short phone call. The GP really needs to study. It's easy to let the patients reach out to us. So we follow them ourselves, and we also say after the treatment, if there is something, please phone.
Thank you both very much, Lisa Hendricks and Jacob Sands. I would encourage the audience to look at the other 2 videos in which we cover different aspects of limited stage small cell lung cancer and immunotherapy.